Hello everyone, and welcome to this Psychiatry Consortium webinar, which will provide an introduction to our current funding opportunity, and it will highlight the application and review process. Next slide, please. So I'm Dr. Patel, Partnership Manager for the Psychiatry Consortium, and I'll be taking you through this webinar today. We'll be joined by Dr. Kathy Liu, an MRC Clinical Research Training Fellow at the UCL Division of Psychiatry, and an old age psychiatry specialty trainee who will provide an overview of the landscape and will touch on potential pathways to target. We'll then hear from a selection of our consortium partners, Dr. Bastian Hengerer from Boehringer Ingelheim, Dr. John Isaac from Johnson & Johnson Innovation, and Dr. Rob Pinnock from Biogen, who will provide valuable insights on what makes a good target and project. John, Bastian, and Rob are all experts in neuroscience drug discovery, and they represent 3 of the funding organisations within the Psychiatry Consortium who will be selecting projects for this call. So for those of you that are familiar with the Psychiatry Consortium, you'll see that the application process is similar to that of our previous call for applications. But I will cover the process again for those of you that are new. I will also cover key submission dates and deadlines, and I will highlight the resources available to support you through this application. We appreciate that each project is different and we want to provide you with tailored guidance. So please feel free to book in some time with us to discuss your application and to ask us any specific questions you may have. And the link for that will be in the chat below now. Next slide, please. So the Psychiatry Consortium launched back in 2019 in response to a huge patient unmet need in psychiatry with a primary focus on medicines discovery. The Psychiatry Consortium aims to bring together our increased understanding of disease biology and emerging genetic data in academia, and our extensive drug discovery know-how of our industry colleagues. We then inform new efforts in drug discovery. We support academic industry collaborations to enable the robust validation of therapeutic targets and screening assays to industry standards, and this is truly a collaborative effort. Through our funding scheme, we offer funds to support the discovery and development of new drugs, but moreover, we are facilitating collaboration and access to industry and commercialization know-how. The consortium partners have committed up to £4 million in research funding to deliver up to 10 projects that would be deemed too high risk or too challenging to take on in isolation. By acting as a syndicate, the partners collectively share the funding of and therefore the risk associated with drug discovery. To date, we have successfully launched and are in the process of delivering 2 projects, with our 3rd project currently in development. Next slide, please. So the Psychiatry Consortium is a strategic collaboration of 2 leading medical research charities and 7 pharmaceutical companies. The consortium is managed by Medicines Discovery Catapult and is supported by Wellcome via a grant which funds our academic outreach work. Next slide. Together, we pull through exciting novel ideas from global innovators in academia and SMEs, and we translate them into validated drug discovery targets, ready for uptake into the drug discovery pipeline. We work extensively with our funding partners, who not only fund projects, but are there to provide expert drug discovery know-how and commercial insights. We work with 2 partner CROs, so that's Charles River Laboratories and Evotec, who are global experts in neuroscience drug discovery, and they support our project review, development, and delivery. We have Wellcome, who supports our global outreach efforts. And we as Medicines Discovery Catapult are acting as a managing partner to provide overall management and governance. Next slide. So in addition to project funding, a key aspect of our work is to engage the research community globally and to provide opportunity for collaborations. Earlier this year, Medicines Discovery Catapult and Alzheimer's Research UK came together to co-develop a target product profile, also known as a TPP, for agitation in Alzheimer's disease. This was followed on with a webinar to help stimulate investment and interest in developing new treatments for people living with dementia. This process highlighted a huge challenge. Alongside cognitive decline, many patients with dementia experience behavioural and psychological symptoms, such as aggression, agitation, and depression. Agitation affects an estimated 35 to 50% of people living with dementia. The impact on people living with dementia and their carers are high and are often issues that precipitate the move into assisted living facilities. The Psychiatry Consortium has always had a clear priority to support the discovery and development of new treatments for psychiatric conditions of dementia. When we launched the consortium, we spoke with Emily, who shared her story with us. In 2010, Emily's mum, Janet, was diagnosed with early onset Alzheimer's disease. For the family, this agitation symptoms were one of the hardest things to deal with. Eventually, they had to take the difficult decision for her to go into a home as it became impossible for them to provide the care that she needed. Currently, there are very few treatments available to treat psychiatric symptoms of dementia. Those that exist, such as the off-label use of antipsychotics, have adverse side effects and a limited time period during which they can be used. The Psychiatry Consortium is dedicated to putting patient unmet need at the heart of what we do. Understanding the challenge of treating agitation in dementia and the need for new treatment options via the development of our TPP, plus our long-standing desire to fund innovative research projects for psychiatric symptoms of dementia, has galvanised us to focus this next funding opportunity on this particular topic. So whilst the TPP was specific to agitation and Alzheimer's, this funding call is for the broader remit of agitation in dementias. Dr. Kathy Liu was involved in the development of the TPP, and you may recognise her from our previous webinar where we launched that piece of work. Today, we welcome Kathy back to talk in more detail about the research landscape and opportunities for novel targets for agitation in dementia. Kathy has kindly pre-recorded this next talk, and as such, we won't be able to take any questions today. Over to you, Kathy.
Hi, my name is Kathy Liu and I'm an old age psychiatrist and a PhD fellow at UCL. And today I'm going to present an overview of agitation in dementia and potential pathways to target for treatment. So in this presentation, I'm going to briefly talk about why agitation is important, especially in Alzheimer's disease. I'm going to describe some of our current understanding of the neurobiology of agitation in terms of brain circuits and neurotransmitter systems affected. I will also give an overview of current phase 3 trials for agitation and Alzheimer's disease. And lastly, I'm going to describe some emerging mechanistic findings that could contribute to the identification of biomarkers and targeted drug development. So agitation is common in dementia, and it affects around 60% of individuals with dementia at any given time, and a higher proportion become affected as the dementia progresses. It can be one of the most challenging behaviours to manage, especially if it's severe or frequent or associated with high levels of distress or risk of harm to the individual or other people. So since 2015, there has been a research definition of agitation in dementia, which is inferred or observed evidence of emotional distress associated with motor overactivity and/or physical or verbal aggression, which has been persistently occurring for at least 2 weeks. So understandably, it's a syndrome that reduces quality of life, and it often leads to someone being admitted to hospital or a care home if they can't be managed safely in their own home. And once they are in a care home, they often require more in terms of health and social care resources. And in terms of treatments, for those who don't respond to non-drug interventions, or in whom the risk of harm or distress is very high, the best drug option we currently have, in the UK at least, is short-term use of antipsychotic medication, which are only modestly effective, and they also have harmful side effects, which include Parkinsonism, falls, and increased risk of death. So it's clear that we need a better understanding of what underlies agitation in dementia so that we can develop better and more targeted treatments. And there is likely to be an interaction between both individual and environmental factors that contribute to agitation. And the strongest individual risk factor is disease severity. which points to potential biological targets that can reduce agitation propensity. So Alzheimer's disease pathology, i.e. tau and amyloid pathology, is associated with increased agitation relative to other neuropathologies. So this recent study found that after accounting for differences in age, sex, and time between clinical assessment and death, agitation was 57% more likely to occur in the presence of Alzheimer's disease pathology, shown in this red box here. So we also know that Alzheimer's disease is the most common form of dementia, accounting for around 70% of all cases. So this slide just highlights that while it is possible that agitation results from common final pathways and may have overlapping treatment targets across different types of dementia, there is justification to look at agitation within specific types of dementia separately. And my next few slides focus on some findings in Alzheimer's disease. So there is strong evidence that the extent of Alzheimer's disease pathology, so amyloid and tau, relates to the occurrence of neuropsychiatric symptoms, including agitation. Based on multiple neuroimaging studies, agitation in Alzheimer's disease appears to be associated with deficits in both the structure and function of specific brain networks involved in emotion regulation. And these regions include the frontal cortex, the anterior cingulate cortex, posterior cingulate cortex, amygdala, and hippocampus. So in the context of increasing cognitive impairment, this might lead somebody with Alzheimer's disease to misinterpret potential threat and or respond with heightened reactivity to uncertainty in the environment. And this might predispose the individual to developing agitation. So it's possible to probe these brain networks and processes experimentally, and this may be one way to identify novel treatment targets. In addition to neural networks, there are specific neurotransmitter systems that have been implicated in agitation in Alzheimer's disease. So we investigated this in a systematic review a few years ago, and we found evidence for the disruption of multiple neurotransmitter systems. These included serotonergic system deficit, and the exact nature or location of this deficit was quite unclear, and this was partly because the serotonergic system is very complex, and also because many of the studies were inconsistent. We also found evidence for relatively preserved dopaminergic function, and there was more consistent evidence for relative overactivity of the noradrenergic system. We also found a small number of studies that reported associations with the acetylcholinergic system and the GABA system, but there weren't really enough studies to make general conclusions about their involvement. So in my next couple of slides, I'm going to zone in briefly on the noradrenergic system in Alzheimer's disease to explore why this could be a potential target for agitation. So the locus coeruleus is a cluster of noradrenaline producing neurons in the brainstem, which is shown here in this diagram by this red blob. And it's the main source of the brain's noradrenaline. And it also happens to be the earliest site where Alzheimer's disease related tau pathology accumulates before it subsequently affects cortical regions. And because the locus coeruleus noradrenaline system plays an important role in the response to stress and influences attention processes, wakefulness and arousal, emotion regulation, and other peripheral functions, it's plausible that Alzheimer's disease related changes to this structure and system may impair the normal regulation of cognition and behavior that underlies agitation. There was a recent study published last month, which was the first to report results relating neuroimaging measures of locus coeruleus integrity with neuropsychiatric symptom severity in early Alzheimer's disease and MCI, or mild cognitive impairment. So this colourful region here represents the locus coeruleus, and it appears as a bright, hyper-intense region on these MRI scans. And the brightness correlates with how well the locus coeruleus is functioning and how much it has degenerated. So the study found that although locus coeruleus integrity progressively declines as Alzheimer's disease progresses, individuals who had higher locus coeruleus integrity showed more severe impulse control symptoms. And this finding supports the concept that there may be compensatory overactivity of the noradrenaline system, which may predispose individuals to developing agitation. And this also implicates noradrenaline blocking drugs as potential targets, as potential treatment targets. So this slide just shows an overview of past and current drug treatments for agitation and Alzheimer's disease. And this figure is from a systematic review that we did of 52 registered trials in the clinicaltrials.gov database. And it shows the landscape of drugs investigated for agitation and Alzheimer's disease over the past 25 years. And studies have been arranged according to their start date on the bottom axis and according to their sample size along the vertical axis. So you can see that in terms of ongoing phase 3 RCTs, there are currently 2 studies of brexpiprazole, which is an atypical antipsychotic targeting mainly the dopamine system. There's 1 study ongoing of escitalopram, which is an SSRI antidepressant targeting the serotonin system. There's 1 trial of nabilone, which is a synthetic cannabinoid. And there are 3 ongoing studies of 2 dextromethorphan containing drugs, which is the active ingredient in many cough syrups. So this is AVP 786, 2 studies, and AXS-05. So dextromethorphan targets this multiple neurotransmitter systems, including the serotonergic and the glutamate systems. We're going to have to wait to see how these drugs under investigation will perform under compared to placebo or risperidone, which is currently licensed in the UK to treat agitation. But here I've shown the findings for the drugs from earlier phase 2 or 3 studies, which all showed favourable quantitative differences of between 2 to 4 points compared to placebo on a scale called the Cohen-Mansfield Agitation Inventory. And this was over study periods of between 5 to 12 weeks. And just to say that there was no data available for AVP 786, and I've shown results here from the citalopram CITAD trial, because the escitalopram study was set up based on finding in this trial that a specific structural configuration of the drug in the form of escitalopram was associated with a higher likelihood of treatment response and a better side effect profile, and the CMAI in this trial was a secondary outcome. So what's notable is that these effects are comparable to the modest effect of atypical antipsychotics of around 3 points on the CMAI. And this means that when these studies are eventually published, it will be important to also consider the drug's side effect profiles and any clinician-rated global change scores to assess whether any treatment-related differences represent a better option to what's currently available. And depending on these findings, these agents may also provide additional insight on treatment pathways to target. So it's interesting to note that virtually all clinical trials of agitation and Alzheimer's disease have investigated treatment-related outcomes after several weeks of treatment, which is fine for agitation, which is, which occurs relatively frequently, but may not be so relevant for acute agitation, which is usually severe and associated with a high risk of harm, but may not necessarily occur frequently. And here's an interesting study published just a month ago on the efficacy of a sublingual alpha-2A adrenoreceptor agonist after 2 hours of administration in patients with bipolar disorder who had mild to moderate levels of agitation. And this drug has the effect of blocking noradrenaline activity. And the company is now looking into planning phase 3 trials in agitation and Alzheimer's disease. So this slide just highlights that there is scope and an unmet need for short-term trials in agitation, in dementia, to investigate drugs that can treat acute or intermittent agitation. Another consideration is how we define agitation. So neuropsychiatric symptoms tend to cluster into symptom domains, where groups of symptoms co-occur frequently. For example, using the Neuropsychiatric Inventory, which is a commonly used scale to measure agitation, the agitation aggression subscale frequently co-occurs with disinhibition, aberrant motor activity, and irritability. And so it has been proposed that a combination of these subscales are valid in detecting and measuring a broader definition of agitation. Agitation may also be measured as a subdomain of a broader behavioural domain. So for example, using the mild behavioural impairment checklist, which is designed to detect neuropsychiatric symptoms in a mild cognitive impairment population, there is a domain on this checklist which is specific to impulse control behaviours, and this includes agitation as well as symptoms such as impulsiveness, disinhibition, and responses to reward. And this is relevant because it may be that some mechanisms or behaviours not conventionally measured in agitation studies could overlap with or even underlie what we observe to be agitation, and therefore could be potential treatment targets. So an example of this is impulsivity or response control. This is not explicitly measured on agitation scales such as the MPI, but there's likely to be some overlap. And there are potential treatments targeting impulsivity in other neurodegenerative conditions such as Parkinson's disease and frontotemporal dementia. Relatedly, virtually all measurement scales for agitation are based on subjective caregiver or clinician report, and this may make them prone to reporting bias. So what would be helpful is to have adjunctive, easy to obtain and more objective markers of agitation. We currently don't have any validated biomarkers of agitation, but this may change as we continue to understand more about the neurobiology underlying agitation. So clinical measures of agitation are always going to take precedent, but adjunctive markers are important to identify novel treatment targets, to stratify participants in trials and identify those at high risk of developing agitation, and to understand and measure treatment response versus non-response. So there have been some recent developments in progressing towards potential novel markers of agitation, and I'll give some examples of this. So mild behavioural impairment, or MBI, is a recently defined construct describing later life neuropsychiatric symptoms in people who do not have dementia or any formal psychiatric diagnoses. And MBI may represent an at-risk state because these individuals have a higher risk of subsequent cognitive decline and dementia. And what would be interesting to know is whether specific MBI domains, such as the impulse control domain that we saw earlier, confers a higher risk of developing subsequent neuropsychiatric symptoms such as agitation in dementia. A second example is coming back to the locus coeruleus. We saw earlier how higher locus coeruleus integrity in early Alzheimer's disease was related to greater impulse control symptoms. And it also appears that for impulsivity in Parkinson's disease, the treatment response to a drug called atomoxetine, which is a drug that increases noradrenaline levels in the brain, depended upon baseline locus coeruleus integrity. Specifically, individuals who had lower locus coeruleus integrity showed a greater response to the drug. So this is an example of how baseline biology might predict treatment response. And my last example is from my PhD work, which has found some preliminary support for the involvement of the autonomic system in agitation propensity. And the autonomic nervous system can be assessed using physiological measures, which are usually quite easy to obtain. And together, these examples just highlight the potential of markers to identify new targets and stratify participants and understand treatment response. So to conclude, agitation is a common and important syndrome in dementia for which we need more targeted treatments. Clinical trials need to show clinically meaningful differences and acceptable side effect profiles to be used over existing antipsychotic drugs. And trials could also look at the treatment of acute agitation over hours or days, in addition to agitation over several weeks. And lastly, a growing understanding of the underlying neurobiology of agitation in dementia is leading to the identification of potential agitation markers and treatment pathways. And thanks very much for listening.
Thank you so much, Kathy, for your overview of the landscape. So the Psychiatry Consortium exists to find new treatment avenues in the hope that this will ultimately provide new opportunities for patients. And with that, I would like to introduce you to our latest funding call, welcoming novel targets for the treatment of agitation in dementia, which opens today. We are looking for novel targets which require validation in order to catalyse the development of novel treatments for agitation associated with dementia. Studies that investigate novel targets for related psychiatric symptoms of dementia, such as impulsivity, anxiety, disinhibition, aggression, will also fall in the scope of this call. Given the challenge of translating the findings of animal models of psychiatric symptoms of dementia to the human condition, projects which utilise alternatives to preclinical behavioural models are encouraged. We are looking for projects which build the link between the target, its pathways, and the human condition via other techniques that use a translational biomarker such as neurochemistry, electrophysiology, and imaging. This call is specific to psychiatric symptoms of dementia, so projects focusing on disease-modifying targets for the core pathology of dementia and Alzheimer's disease, so for example, tau pathology studies, will be out of scope. We accept applications from research institutions worldwide and also from small to medium-sized companies. Applications can be standalone, or they can also be in collaboration with other organisations. Projects can be up to 2 years in duration, and the budget allocated to each project is evaluated on a project-by-project basis. And this will be dependent on the number of funding partners contributing to the project and to the extent of validation required. So to give more information on exactly what the funding partners are looking for, we will now hear from a selection of our consortium partners. We have Dr. John Isaac, who is a Senior Director for Neuroscience External Innovation at Johnson & Johnson Innovation. We have Dr. Bastian Hengerer, who is the Director for CNS Diseases Research at Boehringer Ingelheim, and Dr. Rob Pinnock, who is Director of External Innovation at Biogen and is based in the UK. Bastian, John, and Rob sit on the consortium scientific committee, and they review applications to our funding call. Their insight is invaluable today, and we will hear more about what the partners are looking for in this funding call on what makes a good proposal. So thank you all so much for joining today, and I'm each going to ask you in turn if you could please explain in your opinion, what makes a strong application to the Psychiatry Consortium, and in particular for this call, what are you hoping to see? Bastian, if I could please start with you.
Okay, so what I hoping to see, so I'm not really hoping to see new targets, a novel target. I'm hoping to see a novel therapeutic concept. So a therapeutic concept to approach the symptoms which we are discussing about right now. And so I want to see a strong concept, the biology behind it, understanding the underlying cause of these symptoms and a rational approach for treating it. So all our treatment approaches at Boehringer, finding new therapeutic concepts, is based on the research domain criteria framework. We are using this as a research strategy, and I just see that ECTA posted the link to the RDoc, to the NIMH homepage, that you can have a look if you're not really familiar with the RDoc concept. But it describes a rational approach from with the understanding of the brain circuitry right away in the middle, and going, let's say, downwards, understanding the cells which are involved in molecules and potentially even genes, and on the other way, the behavior, the symptoms, and what is the patient doing, and linking these different aspects of the continuum between preclinical basic research and clinical research. So I'm really very much interested in any new therapeutic concept which is based on the circuit biology of the symptoms and symptom domains which we are just talking about. So symptom domains here is definitely cognitive symptoms, arousal, but also sensory motor systems. And the constructs, the RDoc constructs below cognitive control, response inhibition, motor action or motor inhibition, concepts which are related to these constructs give the underlying biology. So if you have an idea about, let's say, a neurotransmitter receptor or an ion channel, which is expressed specifically in cells of a certain brain circuit, which is involved in this agitation domain, that's what I'm looking for. And so it does not really matter at the moment on which unit of analysis you are coming, whether the target idea is more coming from the circuit biology or from the molecular biology. We will find a way to explore it together. But on the other hand, of course, this also excludes really well-known targets. So we are not interested in another wave of modulating, for example, the metabotropic glutamate receptor. Also, no repurposing of an old drug is not in our scope, what we are looking for. And it has been mentioned by Kathy before, biomarkers, of course, is a very important idea. And if you can link a biomarker to your target proposal, then of course that's an extra bonus point. Okay, so far I think that's more or less describing what we are interested in.
Thank you so much, Bastian. And yes, if I could just highlight the link to the Research Domain Criteria Initiative that Bastian has shared with us, please feel free to go there and have a look in more information. Thanks again, Bastian. So same question to you, please, John. What are you looking for?
Yeah, thanks, Agitation. And actually, Bastian covered a lot of it. I think you know, pharma are fairly aligned in a lot of these things. So we're looking for targets or target biology areas that will meet unmet clinical need, you know, in areas, for example, cognition, aggression, agitation, and psychosis, that differentiate from standard of care, because many of the treatments patients are treated currently with things like risperidone. And I think Kathy's talk really nicely highlights some of the clinical symptoms that are not receiving good treatments. And secondly, then new targets or targets biological pathways that are likely to influence these clinical phenotypes. And I think the challenge for the field is identifying novel targets. Where do you get the data from? Traditionally, a lot of work has been done through animal models of behavior. Unfortunately, those are found not to have translated well to clinical success. So currently, they're quite out of favor within big pharma, and J&J in particular, for identifying targets. So the targets really need to come from human clinical data, human genetic data if possible, or from understanding of circuits that you want to influence in the human brain. And I think Bastian touched on this as well. There's quite a lot of data now using brain imaging, for example, seeing changes in levels of arousal, for example, reward processing, cognition, where you can identify specific circuits in the human brain that can actually be back translated and measured in animal models. And identifying targets that influence those circuits' function will then allow you to then take those targets, ideally one has a therapeutic manipulation, and then you can measure the effectiveness of the molecule in a preclinical model, and then translate it back into effectiveness measured in human subjects with, for example, imaging approaches. So that's sort of the ideal path we see. So a target that's identified from human disease that you can then measure in a rodent model when you have a suitable molecule made, and then you can translate back into humans. Obviously, this call isn't going to be able to do everything, but we're really interested in novel areas of biology. So, you know, experts have got ideas about novel areas of biology and how to therapeutically modulate them, or to think about existing targets where there's novel chemical matter, novel drugs being developed. But I guess the last thing to say, it's important to avoid areas that have been worked on extensively by Big Pharma previously. And again, Bastian's have highlighted this, because often those are such well-trodden paths, and pharma has used its vast resources against those targets. And if they fail to come up with a good drug, as an academic smaller group, you've got to have extremely good reason to believe why you're going to have done better than the Big Pharma. Now, you might have a great new idea in that target, which is great, but often it's going to be hard to compete with previous work that Big Pharma has done. So really looking for very novel areas, novel targets in biology would be the key. Thank you.
Thanks so much, John. And over to you, please, Rob, if you could please provide your insights as well, that would be great.
Yes, I am in a lucky position because I've heard Bastian and John before me. And I just want to, first of all, I just want to reinforce what they've said. This is going to be about a really clear understanding of pathways, and if there's neurochemistry that supports that, as those pathways as well, that's very important. But you've heard from Kathy's talk, which was really, it's very good to see that people are starting to look for biomarkers. Now, as both Bastian and John have said, there's this immense sort of toolbox, if you like, of existing drugs which are used in patients which provide some or no, maybe little benefit to the patients. But then we're seeing some who do get, but what is the question then? What are we missing in those existing therapies that may be being picked up in some of the neurochemistry or any of the existing biomarker work that has been done, which would take us into a new way of thinking about how do we treat this disorder, agitation in AD? How do we treat it? And what particular part of the pathway that points us to, and how would we intervene in there successfully? So it's a very sort of integrated approach. The things that are sort of likely to be out of scope are genetics. And as John said, animal models are probably out of scope until we have a good understanding of the sort of target. And then we might obviously at some later stage do some animal work to make sure we've engaged a similar sort of pathway in a model so that we can take a pharmaceutical agent. But that's probably beyond the where we are now with this call. It's really about identifying pathways that are very important that we have, and as Kathy said, overactivity in the noradrenergic pathway, but very important. Is this something that we can influence in some way that we're not able to influence with our current toolbox of existing pharmaceuticals? What do we understand about the pathways and the neurochemistry around those? And if there's anything that comes out of that in terms of biomarkers that enable us to actually establish whether we've got a good chance of success in clinic, that's incredibly useful too. So that was an awful lot of information I've given in one sort of short summary, but that's, I think, really what we're looking for here.
Thank you. Thanks so much, Rob. That was really, really useful, really insightful. We've heard from the partners, on the importance of the back translation as well. I think we have a bit of time to take a couple of questions, so we can have some questions in the Q&A box. But while we wait for them to come through, maybe I can just start by asking a question or two. So In terms of the review process, we place a strong focus on the link between the proposed target and the psychiatric condition. So what kind of evidence are you looking to see in a proposal to support that link between the proposed target and the psychiatric condition link? Would you like to answer that, Rob?
Oh, that's a tough one. You suddenly dropped me on that. Just clarify exactly what you want from that, from me.
Yeah, so I guess in terms of like what are we looking to see in a proposal? So what evidence in terms of what previous evidence have they generated in the team, in the department?
Yeah. Okay. Right. So essentially it's end to end. So there's been some work which has been used in some way to establish that there is likely to be an alternative route into a potential treatment. What is the data that's backing that up? And what would you propose to do with the existing experimental data that's been generated? How would you take it forward to get to a fairly near-term inflection point, given that the funding isn't inexhaustible here, to make us sort of change the direction either of that program or of some of the things that we're doing? How would it enable us to sort of make a decision on where to push and where not to push? And again, that can use, some of it may involve some of the existing therapeutics to show they do something, but they don't do enough of what is desired for that particular pathway. So that's really what I'm looking at, end-to-end thinking about, I need to take it from here to here to make a different decision to the one that I'd have made before.
I mean, actually, you could say, you know, if there was a clinical molecule that maybe has polypharmacology, which is shown to be effective in treating one of the symptoms that are desirable, but that molecule is not ideal for many reasons. And then if you can identify what the target is of that polypharmacology, which is mediating that desired effect, and then coming back into an animal model and showing that you can detect a similar sort of a proxy of that, translatable proxy, then you could say, now you want to start a drug discovery program selectively after that target. Here is a translatable biomarker. Here's evidence that it's actually going to be efficacious in the clinic. And then you can then start to think about how do you modulate that target selectively. So that would be an interesting one. Mm-hmm. That could sort of stimulate a drug discovery program in a pharma company, for example.
Yep.
And maybe ketamine is a good example for this. There is a clear effect, antidepressant effect in the clinic, but what is it doing? What exactly is ongoing? Studying which receptors might be activated, what is the pharmacokinetic and pharmacological profile of it, what is ongoing, which circuits are involved, and then using this as a basis for specifically looking for the beneficial effect and leaving out the unwanted side effects. And of course, this principle can be applied to many of the old dirty drugs.
Yeah.
Yes, and just taking that a little bit further, it's not only what works better, but if there's evidence that has been gathered of what actually makes things worse, that's actually very useful as well, because it's telling us don't go there, you know, avoid that at all costs.
I guess the other thing you think about is risk factors, genetic risk factors. So there are some genetic associations for risk of psychiatric symptoms in neurodegenerative disease that are starting to be uncovered. So again, if there's novel genetic studies from cohorts of patients where the risk of developing, for example, psychosis associated with Alzheimer's disease has been studied, and there's targets coming up in that would be really interesting. So those sorts of ideas also, I think, are really interesting for us.
Thank you. Thanks for that. So I guess if I could pick up on something that you mentioned, John, when you were speaking earlier. So I guess we're looking in this current call for novel molecular targets for psychiatric conditions. Would you be able to please comment on your definition of novelty? So for example, if anyone is wondering, who wants to apply, is their target novel enough? What would you say to them?
I think, the most novel things are new targets that if you scan the literature, there's no molecules being created for, or there's no molecules being created for brain diseases. So that's one class of targets. And those are often the sort of genetic risk factors that emerge, with newer genetic studies. And then understanding how you drug that target or where it is in a biological pathway and how you drug another node in that pathway is important. So that's one. There is a class of targets, but these are targets where they are subtypes of targets that have already been drugged. So subtypes of neurotransmitter receptors or subtypes of subselective blockers of enzymes or other targets, where in the past less selective molecules have been made. But again, I think with that latter set of targets, if pharma have worked on it already, often there has been attempts to make more selective versions that have failed. So I think coming to that with some insight as to how you would selectively drug that novel subtype of the target would be important.
Thanks, John. Is there anything that you would like to add, Rob or Bastian, for that?
Yeah, it's a novelty. In principle, can also mean a novel pharmacology of a compound, specifically if there are compounds which are active only in the periphery and don't penetrate the blood-brain barrier, but we want to treat brain diseases, then of course this also can be novel. The aspect. The problem here is that most academic partners are not the partners of choice here, because it's the chemistry and or the logistics behind it. I don't want to exclude it, of course, but the probability is maybe less high than coming up with a novel biology.
Absolutely.
And I wouldn't discount something which is a clever new way of looking at something which hasn't been tried before, in terms of some sort of combination of pathways to hit, or it's very challenging, but if there's some people have good ideas. So if it's something that hasn't been thought of before like that, yes, it's interesting.
Thank you. Thanks so much. So does anybody have any last final comments that they would like to add? Are we okay? Thank you so much. So with that, I'd just like to thank our partners for their great insights, and hopefully this will give you a good foundation on submitting an expression of interest. I just wanted to flag as well that we can answer any additional questions that you may have in a one-to-one call after this webinar. So please do feel free, if you have any questions, just book some time with us and we can be sure to answer those in a call. Thank you very much. Next slide, please. Next slide. Thank you. So the first step of this process is to submit a high-level expression of interest outlining the target and its link to disease. So this is going to be submitted via our online portal on the Psychiatry Consortium website, which opens today. So the form is intended to be really brief and it should not take too long to complete. So following on from an expression of interest, if you're successful, you'll be invited to attend a partner meeting where you'll be able to discuss your target and project idea in further detail with the funding partners. Following on from this meeting, you may be invited to submit a full application. Next slide, please. So you can access the expression of interest form directly through our website. So alongside the questions that you see here, we'll be asking for general details for the lead applicant. We'll also be asking for the expertise in that group, so the expertise that people can bring to the project. We will be asking for information on your novel target, as you can see here on the screenshot. Here we'll be looking for evidence linking the target to the disease, and there'll be an option for you to submit a pilot image data if you wish. Please do note though that although your application is fully confidential, we ask you not to submit any proprietary information or novel chemical structures in this application. So from your expression of interest, we want to understand your therapeutic hypothesis. So how would modulating this target provide a therapeutic effect? And a brief indication of expected project deliverables, including any key questions that need to be addressed in order to validate your target. So the expression of interest application window is open from the 25th of April. It's open from today till the 25th of April at 1 p.m. You can submit multiple applications for different targets, and you can discuss your ideas with us before you apply. All you need to do is just book a one-to-one meeting with us. At this stage, we don't require any of the information that's in the top right-hand box, so any details on budget or approval from university research finance departments. Next slide. So if your application is of interest to multiple partners, you'll be invited to meet those partners in a virtual meeting on the 10th of May. The meeting will be around 40 minutes long, and this will include a short presentation from you to introduce your proposal, followed by a discussion with the partners. This is an opportunity for you to shape your project and for you to understand the aspects of the project that are most of interest to the industry partners, and for them to give you a steer ahead to submitting a full application. Next slide. So in the full application, you will expand upon your initial expression of interest, and you will outline your proposed project plan. Now, this will be a high-level plan, high-level overview, highlighting the key steps in a logical manner. It will include key milestones and deliverables of the project duration. Applications will be accepted online between the 11th and the 23rd of May. But please note that you must submit an expression of interest and attend a partner meeting in order to submit a full application. Next slide. So you've heard directly from the partners on exactly what they're looking for in a research proposal. So they'll be particularly looking to see whether the target is sufficiently novel and whether the evidence provided is sufficient to indicate a link to the disease. We will also look to see whether there's any tool compounds available, or if any can be developed to support the project. And most importantly, do you have a valid therapeutic hypothesis for how modulation of your proposed target will provide a therapeutic effect? Next slide. So we aim to turn around applications to this call over in the next few weeks, so please be mindful of the timelines which are shown here. There'll be no extensions granted. You can sign up to our newsletter to receive reminders of these deadlines, and the sign-up link can be found in the chat or on our website. Next slide, please. So we've provided you with quite a lot of information today. This webinar is recorded and it will be available on our website so that you can go back and rewatch any of the sections in your own time. We also have lots of other resources available for you on the website, including frequently asked questions, our terms and conditions, and all of our previous webinar recordings. We also offer you the opportunity to speak with us directly before submitting your application, and we really recommend that you do so. Please feel free to contact me directly via the website and arrange a call to discuss your research project in further detail. And the link should be in the chat now. Next slide. So with that, we come to the end of this webinar. I want to thank our speakers, Kathy, Bastian, John, and Rob, as well as to our audience for listening. If you do need any further information, please feel free to reach out and do sign up to the mailing list so that you are notified of all of the deadlines, upcoming events. And I'm really looking forward to meeting and possibly working with many of you on some exciting new opportunities. Thank you so much.